So we'll go ahead and get Dr. Blanco to give us a little bit of a welcome, and then we'll get started. Thank you.
Thank you, Langston, and thank you to all of the LAUSD staff and teachers and support groups. So we're very excited to have you here at UCLA. We are going to have as Dr. Holly mentioned, a nice session with multiple disciplines for you. And these are the schools that are here today. So if you guys didn't know each other, there we go. This is very exciting for us to have you all. So as a recap, this is basically the last session of our program that we initiated back in October. And you will recognize some of those sessions here. And so I think one of the important things is that as much as we are focused on learning new things and of course improving our skills in many aspects of science and biology, and you guys probably have all that chemistry and physics and mathematics in the back of your heads, all of those things are very important. Part of the reason we want to organize this is because when you go into a career, eventually you're gonna integrate all of this knowledge and all of this learning, and eventually it is also very important to learn to work in teams and basically collaborate with other experts and learn from other disciplines. And so this is just a brief picture here of what looks potentially as a chaotic scene in the ICU where many doctors and people and nurses and experts are working together, but if you actually identify them, you're seeing a lot of different disciplines. You're seeing medical students, pharmacy specialists, nurses, lead nurses, doctors, different degrees of training of different disciplines like advanced nurse practitioners and other types of trainees, plus of course all of the other professions that integrate in the ICU. So we welcome you. We're very excited for you to be here and enjoy. Thank you.
Great. Well, thank you, Manny. So I want to start with a case, right? Because a lot of what we do in medicine and in healthcare is case-based. And interestingly, this is kind of a case that we would present to people who want to get their board exams passed for neurosurgery. And what we do is we present a case, show them the films, what the patient give a brief history exam, and then we ask them what they would do. And then we actually score them based on their responses, and we determine whether they pass or fail, okay? And so this is actually the type of case that if I were given an exam, I would ask. So you guys are kind of gonna get a little bit of a sneak peek on what you might be doing later in your life. So the history of this patient, this is a 21-year-old intoxicated woman who suffered a fall from a balcony. So rule number one, don't get intoxicated. That's number one. She had a brief loss of consciousness at the scene, and then she was noted to have scalp swelling in the left frontal region of her head. When she came to the emergency room, she was afebrile, so temperature was normal. Her pulse was 60, blood pressure 150/90, which is a little bit high, and her respiratory rate was 16, which is in the normal range. She was slightly drowsy, meaning that she couldn't keep her eyes open, but if you spoke to her, then she'd open her eyes and then she'd kind of close them again. She was oriented to her name only. She did not know the location or the date at all. When we examined her, both her motor exam and her sensory exam, as well as her cranial nerve exam, were all intact. We then got a head CT because of her fall and the fact she was drowsy. Anybody see anything there? What do you think about this head CT, the brain CT there?
She has a brain.
All right, I see in the front. What do you see?
That it looks kind of bright on the right side of it.
Right there.
Yeah.
Right, that doesn't look normal, right? So one of the good things about looking at imaging is we want to see symmetry, right? So if someone has pneumonia, you look at both sets of lungs on either side, and that's a great way to look for problems. So you had good deductive reasoning there, right? So what we see is this blood. This is what we call epidural hematoma. This is a blood clot that's on top of the brain, right? And it's causing compression of the brain, and you can see how the brain is flat along here, and how there's actually what we call midline shift. so that these ventricles, the area in the dark here, you can see how everything's kind of bowed over and shifted over, okay? So what do we do next? What do you guys think? We have something like that. What's this patient's sleepy, they've got a blood clot on top of their brain. What are we gonna do?
Surgery.
Burr holes? Okay, so that's an option. So take them to the emergency, take them to the operating room to take out the blood clot, right? So that's a great idea. But based on her mechanism of injury, the fact that she had a fall from a balcony, it made us wonder, is there a problem in the neck also? So who sees something here? Yeah, what do you see? Broken spine, right? So the vertebral body right here at C7 is broken in half right there, split into two pieces. And then this is an MRI showing that one of the fragments is going back and compressing the spinal cord. So now what do we do? Does that look like that probably needs surgery also? Absolutely. So how do we figure it out? What's the next step? Which one do we do first? Who votes do the brain surgery first? And who votes do the spine surgery first? All right. It's about half and half. Well, I'd say let's do the brain surgery first. And the reason is because the brain surgery, if you don't take that hematoma out, that's something that someone could die from within an hour or so. So we ended up doing that. So you can see now we've evacuated the hematoma, right? So this is a little bit of air that's left from the space where the blood clot was. And here is, you can see now the brain is back expanded and everything looks back midline and not pushed over like it did. And then what I did was the next day, I took her to the operating room to fix her cervical spine. And what I did was I took out this vertebral body and I put in this cage. And what you do is you put the cage in there and then you can turn it and it actually helps to open the spine back up. And then I put a plate and screws on there. And that's what I do as a neurosurgeon. I do surgery of the spine, whether it be traumas or elective surgery like herniated discs or tumors or that type of thing. And I also do surgeries that might be emergencies in the brain, like a hemorrhage from a trauma. And so from where you guys are, what it took me to do was 4 years of college, which I went to UC Berkeley. I then went to 4 years of medical school here at UCLA. I then did a 7-year residency in neurosurgery. This is where I really learned how to do these types of surgeries and practiced and learned. And then after that, I did an additional year of spine surgery training. And then after that, I came back, was recruited back here at UCLA as a faculty member here. And I've been now going on 21 years here as a faculty member. So this is just one way that you can contribute to patients and help take care of people. And there's other great healthcare career paths that you're going to hear about today. And essentially all of these people took care of a patient like this at one stage or another during their stay. And we all need each other and we all work together. So I'd like to next introduce Lauren Yamamoto, who's a clinical nurse manager, and she's going to tell us about what she does, and so you can learn more about nursing. Thank you.
Hi, good morning. My name is Lauren Yamamoto. I'm one of the nurse managers in the Neuroscience and Trauma Intensive Care Unit here. I work with about 100 nurses that we have on staff, and I'll just start by sharing my journey to nursing with all of you before I get into it in a little more detail. So when I graduated high school, I attended a BSN program, a Bachelor's of Science in Nursing program. It was a 4-year program. And from there, once I graduated and obtained my nursing license, then I applied for the new grad residency program here at UCLA. I worked at the bedside for probably 7 years, and then I wanted to professionally develop. So I applied to be a charge nurse. That did not take any additional education. I did that for another 7 years, and then I wanted to further my career. So at that point, I went back to school and obtained a Master's of Science in Nursing so that I could apply to be a nurse manager, and I've been doing that for probably 4 years now. So how do you become a nurse? There's kind of two main pathways that you could take. One is you could become a LVN or a licensed vocational nurse. This takes about a little over a year. The scope of their practice is quite limited. They can provide basic nursing care, but they have to work under the direct supervision of a nurse or a doctor. Or you can become a registered nurse, and you can do that by attending a program at a community college, like obtaining an associate degree in nursing, which is a 2-year program. Or you can go to a bachelor's of science in nursing program like I did and obtain your BSN. Like I mentioned, it's a 4-year program. Just keep in mind, if you're interested in being a nurse here at UCLA, you have to be BSN prepared to be hired as a new hire or to be hired from the outside. If you still are not sure after hearing from all of the experts today, I'm not sure if I really want a career in healthcare, or I'm not sure which specific department, 2 things that you can do to prepare or to kind of give you a little snapshot of what it's like to work in a hospital. You could volunteer. We have a volunteer program here, or you can obtain your certified nursing assistant's license. That just takes a few months. And you can go through different departments throughout the hospital and see what might interest you the most. So I think when I first started working here, I did not know that nurses were used everywhere throughout the hospital. So I made a little list of all the different departments that you could work in if you were to become a nurse. You could work in the ambulatory areas, which is the doctor's office and the outpatient areas. You could work in critical care like I do in intensive care units. That might be a little too much for you, or that might not interest you, and you might be more interested in working in a medical surgical floor where the patients are a bit more stable. You might be interested in procedures like the operating room. We have nurses utilized in all different procedural areas. If you see that helicopter photo there, we have a whole critical care transport team. And this transport team is made up of nurses and respiratory therapists that you'll hear more about later. But they fly in these helicopters and they go all over the county and pick up patients and bring them here so that they can receive the best care. You'll hear later from Sherry about how to be a case manager. We have advanced practice nurses like nurse practitioners, nurse anesthetists, or you can be a manager like me. Really the take-home point is that for nursing, the opportunities are really endless. And I think until I started working here, I did not know all the different ways you could be a nurse. So another thing I wanted to share with you was when I think back to when I was in high school applying to a nursing program, if you really asked me, what does a critical care ICU nurse do every day? I think I probably would have said, I think they check vital signs and maybe pass the doctor the instruments or tools that they need. Talking to some of you today, it sounds like you're all very motivated and you already know exactly what you want to do. So you sound, many steps ahead of where I was, but I will go over the case that Dr. Holly presented and what an ICU nurse would do from our perspective. So when these patients are admitted from the emergency room, they usually come up to the ICU. And when they are admitted, all of a sudden the nurse will open the chart and about 50 to 75 orders are just gonna flood the computer. And so it's up to the nurse to know, what do I need to do first? What is most important? What's an emergency intervention that cannot wait? So they're gonna be prioritizing all their tasks first. They're gonna be in charge of assessing and monitoring the patient. They're gonna be giving a lot of emergency medications to these patients that will help slow that bleeding in the brain and hopefully help save their life. They might be giving some blood products. They're definitely going to be placing IVs and drawing blood. There's a lot of advanced monitoring devices that the physicians might order, and I'll show you a few of those on the next slide. And they're going to be transporting these patients all over the hospital for all of their different imaging that they might need. And this is really important because, like Dr. Holly mentioned, they need to see these imaging at certain intervals of time so that they know the best care that they can provide the patient. But mainly, our main expectation for our nursing staff is that they are patient advocates. We expect that they understand the why behind every order that's going in and the science behind why things need to be done and when. And we want to empower our nurses that if they see an order that comes through and they don't understand it or they don't think it's safe, that they speak up and collaborate with the physicians to make it safe for the patient. So here's some of the gadgets that we use in the ICU. This first one here is called a hemoroam. It's a mobile blood refrigerator that will keep blood cold at the optimal temperature for 24 hours. So while this patient might not require massive amounts of blood transfusions, they might require just a few products here or there, we're a trauma ICU. So our nurses are really highly skilled at administering massive amounts of blood in a very short amount of time. This photo is just showing you what some of the blood products look like. And then I had mentioned to you that we do a lot of advanced monitoring. So this is just one photo of a device that our nurses use to monitor all the different values of the heart to see how hard the heart has to work. And this helps guide the physicians on the different treatments and different medications and drips that they want to order for these types of patients. This to the right is a drain that the physicians will drill down into the head right at the bedside, and the nurse assists with that procedure. The nurse will monitor this and monitor the pressures in the brain, and they can drain off fluid and alleviate some of that pressure. And then here we have some brain activity waves, so the physicians will likely order for this type of case continuous brain monitoring. And our nurses know how to monitor that for seizure activity and different things and report that to the physicians. So lastly, I thought it was very important that I share with all of you some of our nurses' favorite things about being a nurse here at UCLA, something that you might not be able to Google or just find on a website. So I think one of the biggest satisfiers for our nurses is the scheduling. Most of them work only 3 days a week. That's a full-time employee. And so that allows for 4 days off a week. So what does that mean? That allows them a lot of work-life balance if that's something that's important to you, if you like spending time with your family or exploring outside hobbies or passions that you might have. It really allows for a nice balance. One of my favorite things about working here and being a nurse at UCLA is the professional governance. So what does that mean? That means that you can be the change you want to see. If you're working out on the floor and you see a nurse-driven protocol that you think could be improved, or you see an issue with any sort of process, there are committees and councils for everything. And nurses really have a seat at the table here. They really value our opinion and our input. And I can say that that is not the same for all hospitals nationwide. There are a lot of opportunities for advancement. Like I shared with you, when I was becoming a nurse, if you asked me, are you gonna be a charge nurse one day? Are you gonna be a nurse manager one day? I would have said, heck no. But here I am, and the opportunities are endless. And then lastly, I think the reason why everyone's here and everybody's interested in a career in healthcare is because it is so rewarding. I'm not gonna lie to you, the job is hard, the hours are long, but I think when our nurses go home at the end of the day and they're getting a hug from a patient or a family member crying, thanking them for getting them through, one of the toughest, darkest times in their whole life, I think that's what makes everything worth it. So I really, really encourage all of you to explore a career in nursing. I will be around later, and I'm so excited to speak with anyone who's interested, and anything I can do to help any of you, please let me know. Thank you so much.
Fantastic. Okay, great. And so up next, we have Lynn Clarito, who's a pharmacist here at UCLA.
Hello, everyone. I'm really excited to be here and talk about pharmacies. So I know some of you are probably familiar with pharmacists, right? Like you go to a retail pharmacy, Target, Costco, Walgreens, CVS, and you'll need a pharmacist. But I'm a little unique because I'm actually a neurocritical care pharmacist. And the path to get to where I am is going to be slightly different. So when I was in high school, I was like you guys, I love science, I love math, and I honestly didn't know what to do. Like, do I want to be a doctor? Do I want to be a nurse? Maybe not. And like, we didn't have this where you guys get to learn about the hospital setting and different kind of various professionals. So for me, I was very lucky because my science teacher said, why not pharmacy? You like science, you're good in math, and I think you'll be good at it. So during junior year, I actually looked into so many pharmacy programs. And I kind of wanted a more accelerated program where I didn't have to do a bachelor's in science. So I'm from Maryland, so I looked into schools in Philadelphia, and I did an accelerated 6-year program. Like, so right after high school, I went straight to pharmacy school, and after 6 years, I got my doctorate in pharmacy. And the first 2 years is kind of like your undergrad. You do organic chemistry, calculus, and luckily you don't have to apply calculus later on in your career. I only had to take it once, and after that, I got my doctorate. And you could do a lot without pharmacy, right? You can do retail immediately. You could start working. You could also do like pharmaceutical companies, like so you could do a fellowship in large pharmaceutical companies and do like research and development, really develop medications out there with Merck, Johnson & Johnson, Eli Lilly. And you could even do like medical information where you create like brochures and educate the public about medications. But for me, I was a little bit more intrigued in working in a hospital, right? So for you to do a hospital route in pharmacy, you actually have to do a residency, and we highly encourage it. Because the first year of residency, you get to do acute care, where you get to rotate in a hospital in various specialties. So you could do a rotation in infectious disease, the medical ICU, transplant. Transplant in itself is huge, right? Because we have various transplant here at UCLA. We do like kidney, lung, heart transplant. We haven't done brain transplant yet, but maybe someday we could do it. And you get to really learn and see whether or not you want to specialize in a certain area of pharmacy. So for me, I actually was a little bit intrigued of the brain, right? It's so fascinating to me. So there's not very many of us, but I actually did a 2nd year in neurology, right, at the VA UCLA across the street. So it's not a common program. It's very rare, there's not very many of us. But right after I graduated in neurology in my residency, I was actually hired here at UCLA and became a neuro-ICU pharmacist. So I've been here since 2011, and I've been here since. I've never left. So a little bit of my role. So like you could see, I collaborate with a team. So a lot of my days is really looking at our patients. And in one unit in the neuro-ICU, we have 24 ICU beds, right? So the first 2 hours when I come in the morning, from 6 in the morning till almost 8 o'clock, I look at every single one of those patients and review all their medications. Like Dr. Holly said, you can have a patient with an epidural hematoma, and even if they were healthy before, when they come in really sick, you're going to be on an average of 15 to up to 30 medications, right? And each medication, you have to assess whether or not it's the right drug, it's the right route, right? Because some medication you take oral, but here we would give them intravenously, straight to the blood, right? So you could look into that, and then you could also monitor levels, make sure that it's not toxic, right? Because some medication can be really toxic and can really damage like the kidney, the liver, and we want to make sure we monitor that on a daily basis. And then, so we collaborate with a lot of physicians, nurses, RTs, social work, and really our role is to ensure that the medication are really safe and they're also effective. Because if they're not effective, then we have to look for alternatives. And there's some times that we have to look for different routes on how to treat these patients. So in neuro, not only do you get like traumatic brain injury or an epidural hematoma or seizures, we can also have patients with an infection in the brain. And sometimes we actually have to inject intrathecal medication, which we directly inject into the brain, like antibiotics, right? So we want to make sure that they're safe and effective. So what other responsibilities do we have as pharmacists? So medication management is huge, right? We really focus on the medications. We also have to be familiar with the diseases, right? So we need to know the pathophysiology of the disease, right? What causes it, how do the doctors diagnose it, right? And appropriate guidelines on how to treat these diseases. And on top of that, on a daily basis, we monitor these patients very, very closely and we do follow-ups. But besides just medication, we're actually involved in research. So right now I have 2 ongoing research where I'm looking into a fairly new drug and looking into whether or not it's effective in seizures. And the other research I'm doing is literally looking at a medication and whether or not it penetrates the brain. So I'm actually drawing drug levels in the CSF, or the cerebrospinal fluid. So those are some things that I'm working on. But in addition to that, I'm also a mentor and a preceptor. So here at UCLA, we take about 4 residents in first year and 2 in second year when they specialize, and it's in infectious diseases and transplant. And we mentor them, they rotate with us for 4 weeks at a time, and they get to also learn about hospital, and maybe they want to pursue a specialty, right? And if they do, they can go to ID, right? Medical ICU, critical care. A very popular one is emergency room, right? You could do a specialist in ED and work in the emergency room, and even transplant. And even within transplant, you get to specialize in kidney, liver, heart, lung, pancreas specialties. So we actually have a pharmacist for each of those specialties, right? And on top of that, I don't only just mentor residents, I actually also mentor students. So I take students from UCSF and UCSD. I actually currently have a student right now rotating with the team, and I love him, but he'll be okay. And he gets to spend 6 weeks with me and learn about neuro-ICU. And we mentor, and yeah. So really, overall, our goal as a pharmacist is we do play a vital role with the team, right? We work really closely with the physicians. We want to make sure that the things that we're doing are safe and effective and also cost effective. Because a lot of the medications that we do use can cost up to $60,000, right? So if we want to use it, is it cost effective, or is there alternative agents that we could use? And also, ultimately, we want to contribute in improving patient outcomes and as well as their health outcomes. I have my email address if you guys are interested at all.
Guys, thanks for being here. We appreciate it. Like JG said, we could have been anywhere in the world today, but you decided to be with me. So thanks so much for coming out. I am one of the directors in radiology. There are many directors in radiology. I work with the Elite Sports Imaging Team. I'm director of radiology for the Los Angeles Lakers and the LA Sparks. I have a very cool job. Radiology is a springboard to so many opportunities within healthcare. I like to say all roads lead to radiology, so I can give an example of that. How many of you have had, hopefully not, neurosurgery? Raise your hand. Look around. Not many? Great, that's really good news, I like that. How many of you have had an x-ray? How many's had an MRI? Hands up, keep them up, keep the hands up. So x-rays, hands up. MRI, keep your hand, if you had x-ray, keep your hand up. Do you know somebody who's had an MRI or a CT? Everything we do, I like to say, all roads lead to us. Anybody that comes to the hospital, you're probably gonna get imaging or labs. Everything builds off of this. Radiology, most people think x-ray. There's a lot to this. We have x-ray, CT scanners, cardiac vascular interventional radiology, MRI, mammo, sonography, bone densitometry. There's lots of fields that you can go to once you start off getting through the radiology world. Opportunities are vast. My path is unique. I had an accident when I was 14 years old. I was playing baseball. You guys know what a compound fracture is? Anybody? Yeah? What is it?
It's a severe fracture.
Yep. Bones come out. You can see your bones. I have a hole here. It sucked. It was really bad. I had multiple surgeries after that. I have 2 plates on this bone here. Anybody know the name of this bone? Bone's in your thumb up your arm. Somebody said that. I heard radius, yes? Radius, ulna, I have plates on both. And when I was going in for these surgeries, I kept having to go back. I had 3 surgeries to put my arm back together, and there was an x-ray tech. And I came in, and I'm this 14-year-old kid, and I'm looking at this machine, and he saw something. He's like, I'm like, what does this do? He's like, it's a camera that lets you see inside people. And I'm like, okay, that's kind of cool. So I asked more questions. And he came out, grabbed my dad, he goes, hey, your son seems kind of interested in this, can I show him more? So we went back in the dark room, and back in the day, now it's all digital, but you would take an x-ray, dip the film in like you would a regular film, developer, fixer, hang it up, and I could see my bones with these plates on it, and I'm like, I'm in. So I was already on my path at that point. So my path, I went through a bachelor's degree at Cal State Northridge. I did a 4-year degree, you do 2,700 hours, and I went directly into radiology from there. There are also other paths. Community colleges, UCLA works with Cypress College, LACC, El Camino, and there are also private radiology programs. The private radiology programs were expensive, but the LACC program and the junior college programs, very attainable. You can get in there, get your hours in. These images show a mammo room. This is a CT scanner, ultrasound, a regular X-ray suite, MR suite, and another mammo suite. Opportunities are vast in this field. Lots of opportunities are available. Cool part about my job, I work with the Lakers every day. It's a very cool gig. So what I did is once I came out of school, I went directly into, my internship was through Cal State Northridge, and we had to do 2,700 hours in the hospital of training. So what I did is I got married really early, and I told my wife, hey, you know, my shift is from 7 a.m. to 7 p.m. because I knew I wanted to do MRI. My shift was really from 8 a.m. to 5 p.m. But I came in at 7, went to MRI, hung out, went to wherever I had to go that day, ultrasound, x-ray, whatever, and then came back to MRI until 7 o'clock at night. I did that for 2 years. When I graduated, I went to the head of the department and said, hey, is there an opening for me here? And she says, of course, you know everything already. I knew the doctors, I knew the protocols, I put in the time, I did the grind, I put the work in. It's given me a great career. I'm an old head. I've been here at UCLA working for 33 years. I know, dang. I remember you when I heard it. But it's given me a great career. I really do love what I do. Working with the Lakers, who asked about the 24/7 call earlier? Somebody over here. Yeah, that's me. I'm on call 24/7. So whenever we have a home game, this unique situation is that we have to have a physician actually sitting with the players. Dr. Chris Jones or Dr. Daniel Beal are with the players. We also have a physician for the visiting teams. So we're responsible for visiting teams as well. If I'm not at the game, I have to be watching the game, and if somebody goes down, I've been at home and I've taken my phone out and I put it on my dinner table and I'll wait and it'll pop. It's like, okay, Rick, LeBron went down, his ankle looks funny, let's go. And so we rush over to the hospital either that night or the next morning and put these guys together. I am like the grim reaper to these guys. They hate seeing me because they're hurt. They come in like, hey Rick, how's it going? I'm like, sorry, I'm gonna patch you up. But imaging is where it is. I worked with radiology for a long time. I ended up working at Pearl and Jobe on the side. I've always been at UCLA, and that's how I got into the Lakers field. And then we lost a contract, and back in 2016, we came back to UCLA, and I came into the room when we were having our meeting, and it's very official. All the UCLA people are on one side of the table, and all the Lakers people are on one side, and I came in, and Byron Scott was the coach at that point. And he looks up and he goes, Rick, and I'm like, Byron, what's up? And everybody's like, oh, they know each other. So being a kind person, being engaged, doing your job well, it carries. So you never know who you're going to bump into. One of the things I can push into you guys is really important. Find a mentor. Find somebody that can be that professional advisor for you. And if not your mom or dad, find somebody possibly in that field, but somebody who can bounce things off of. Don't wait for chances. Make your own. And my family's from the South, and there's the saying, closed mouth don't get fed. If you have a question, ask.
All right. So next, we're going to hear from Nidra Barlow from Respiratory Therapy.
Hello everyone, my name is Nidra Barlow. I'm a respiratory therapist here at UCLA. I've been a respiratory therapist for the last 27 years. Just like you all, I'm so excited that I'm part of this presentation today because when I was your age, I didn't know what I wanted to go into. I thought I wanted to go into nursing, but then I found out what a respiratory therapist was. So a respiratory therapist. We specialize in medical professional that care, we're a specialized medical professional that cares for individuals affected by respiratory diseases like asthma, COPD, and other causes of breathing difficulties. We assist with intubations in the ICU team to provide life support and help with manage the ventilator. So remember 2020 with COVID? We were there. We were frontline workers there. You know, when you would look at the news, you will always hear about doctors and nurses, but we were there helping assist with intubation, running the ventilators and everything for the frontline workers. We also deliver life-saving medications via aerosolized therapy that help open the lungs, allowing patients to breathe easier. One thing about respiratory, it has grown so much since I've been in this field. Over the last 27 years, it has evolved a lot. There's so many things that we do now. Like here at UCLA, I'm the clinical specialist for a specialized ICU. I work a 12-hour shift, 3 to 4 days a week. We have different areas. We have ECMO for respiratory. We're part of the transport team where we fly out to get patients. You can also work in the pulmonary function lab, the sleep lab, pulmonary rehab. So there's a whole list of things as a respiratory therapist that you can do. When I didn't know what a respiratory therapist was, but I'm so happy that I found out what a respiratory therapist do in the hospital. So that way we can get involved, we're involved with patient care, and I love what I do. But there's so many things that, are out there for you all to look into, and I just wanted to come up here and express about respiratory. There are schools that are offered here in LA. That students actually come here to UCLA and we precept East Los Angeles College, Santa Monica College, LA Valley College, Mount SAC, and Pima. Pima is a school in San Diego. Okay, there are also private schools that you can go to as well. And it's a 2-year program. You come out with an associate's degree, but you can also move up and get your bachelor's and your master's if you want to be in management. I just wanted to come up here and express that. And like Dr. Holly had that patient that came in. So if that patient came in, we would be there with the team assessing the patient, maybe putting the patient on oxygen. If the patient needs to be intubated because they're altered, we will be the person there to assist with intubation, do transports, the CT scan, MRI with that patient on a ventilator.
So our next talk is going to be from Han Tan, who is a physical therapist here at UCLA.
Good morning, everybody. My name is Han. I'm a physical therapist here. I've been at UCLA Medical Center for about 6 years, and I have a total of 8 years working in physical therapy in the hospital setting. So what is a physical therapist? A physical therapist is a healthcare provider who helps maintain, restore, and improve a patient's ability to move and function. That's just a very vague and general definition, but we help patients with in all ages, from newborn to end of life, and all diagnoses. So even just within this hospital, we work with patients after heart and lung transplants, while they're getting treatments for cancer, elderly patients who fell and need help learning how to walk again because they broke a bone, trauma patients like Dr. Holly had mentioned. Just in the neuro ICU, we see patients after spinal cord injury, traumatic brain injuries, stroke. So there's a lot of different types of patients that physical therapists work with and really help patients get up and get moving. Physical therapists can also work in a variety of different settings, such as outpatient, acute care, which is the hospital setting, rehab facilities, such as acute rehab units and skilled nursing facilities. You can also work in home health, as well as sports, just to name a few. So what is the role of physical therapists in the hospital? Well, we actually like to consider ourselves mobility experts. The 2 big reasons why we work with patients is 1, to help them move, because it is so very, very important to get patients up while they're here in the hospital. We don't want patients to be in bed all day long. Early mobility in the hospital helps improve and maintain heart function and lung function, reduce risk of bed sores and pressure ulcers, reduce the risk of blood clots, helps promote muscle tone and reduce stiffness. So it's very important that we help patients move. The other part is for discharge planning. Whenever the doctors medically clear the patients from the hospital, we do want to make sure that there's a safe discharge plan. So how do we help patients move? Well, first we have to chart review. Why is this patient here? What surgery did they have? So like Dr. Holly had mentioned, that patient had to have brain surgery and then also cervical spine surgery. So what precautions would these patients have? Well, after brain surgery, a few of the precautions include keeping the head of the bed at least 30 degrees. We don't want patients to lay flat because that could increase the pressure on their head. Now, depending on the exact type of brain surgery that patient had, when they evacuated that blood, did they remove the bone flap from their head? Because if they did, and now there's no bone flap, then the patient has to wear a helmet anytime they're out of bed, because it's very risky if the patient falls or and hits their head without a bone flap to protect their brain. So we have to do a very thorough chart review, understand the patient's precautions. What lines and tubes does this patient have? We want to know, okay, is there a breathing tube down their neck, or are they using oxygen? And there's drains coming from their head or their back, or they might have a Foley catheter for peeing or a rectal bag for pooping because their body organs aren't really controlling that. So trying to figure out and understanding the big picture before we even go in to see the patient. So then when we actually have chart reviewed, everything looks stable enough, then we go to the bedside and we assess the patient. So physical therapists help assess strength, range of motion, coordination, balance, cognition, and functional mobility. So when I say functional mobility, I want to know, how is this patient able to get out of bed? Are they able to stand? How much help do they need to stand or take steps to the chair? So we assess how the patient's moving and encourage that. Once we assess the patient, we kind of use our clinical judgment to create their physical therapy plan of care. What do we anticipate their progress will look like? We'll create a treatment plan to see how many times a week are we going to work with this patient. Can they tolerate it? And we can track their progress while they're here at the hospital. Another big thing that physical therapists do in the hospital is educate. We want to educate the patient, the family members, as well as nursing staff on how they can help this patient move. Because physical therapy, when we come in, once a day when we do, and that's only a short session. So outside of the therapy sessions, we want to make sure this patient's moving. So a lot of times after I assess the patient, I get a question from the nurse. How are they doing? And they mean, how is this patient moving? And I'll talk to them about, okay, this patient needs moderate to maximum assist, meaning the patient's not doing that much work and I have to help them stand up or balance. So the patient requires moderate to maximum assist to stand and take steps. I recommend you using this piece of equipment to help them get up to the chair. So educating, encouraging, the patients to do their exercises while therapy isn't there, how family members can help move, assist them with the exercises is very important. And then for discharge planning, that's when the patients are more medically stable. So we want to make sure, is this patient safe to go home? And if they're not safe to go home, then maybe they'll need rehab at a short-term rehab facility, such as acute rehab or a skilled nursing facility. But if the patient is safe to go home, well, we have to understand what their home setup looks like. Some patients have a flight of stairs and they can barely stand and take steps to a wheelchair, then I wouldn't think it would be a safe discharge plan if they have, in order to get to their house or into their apartment, that has a flight of stairs, no elevator access. What's the plan? Okay, maybe some short-term rehab until they get stronger, more independent, require less assistance to be able to go home safely. So we factor in how much assistance the patient currently needs while they're in the hospital and how much support the patient has when they go home. So the patient might live at home with other family members, but the family members might be, taking care of young children or at work all day, and they don't have the amount of assistance available to them in order to get up to the restroom. And so we factor that in as well. Different discharge dispositions include home, acute rehab, skilled nursing facilities, and other places like long-term acute care facilities and things like that. And if they were to go home, then we kind of can decide, okay, are they safe to go home with certain equipment? And so then we put in equipment recommendations. They might need a walker or wheelchair, crutches, a hospital bed if they're hospital bound, or other pieces of equipment. And then if the patient also did go home, are we recommending home health physical therapy, or can they go to outpatient physical therapy, things like that. We collaborate closely with other disciplines like case management, social worker, occupational therapy, respiratory therapy. Sometimes I even ask them, when we walk, their oxygen levels go down. What can we do to best support them and get the most activity out of this patient? And we also speak with the doctors and other providers. This is just some pictures of the equipment that I recommend patients can go home with. All of them patients can go home with except for this bottom right one. I'll talk about that in a second. That's only just used here in the hospital. So sometimes patients might need a walker. If the patient had a stroke and they can't use one side of their body, they might need something called a hemi walker, which is, if you think about it, kind of like a cane, but a very wide base of support because it's more stable. As the patient progresses off the hemi walker, they might be able to use a narrow base quad cane. And then if they're doing better, they might just need a single point cane because the smaller the base of the support, the less steady it is. But if the patient's balance is better, then we can progress off to the least restrictive assistive device. Just a picture of crutches. So this is a mechanical Hoyer lift. Sometimes patients are pretty much total care. They're dependent. They cannot safely get from bed to wheelchair without two people helping them up, and they're not doing any work. So we don't recommend caregivers or even nursing staff, anybody to be lifting. Really, at least legally here at UCLA, we should not be lifting more than 30 pounds. So the patient, we're trying to teach them the best way they can use their body. But if they can't do it, and they're eventually gonna go home, because they've kind of plateaued in the progress they've made with therapy, and they've been in and out of the hospital, they're now more so bedbound, and they need that much help, they might need this mechanical lift to get them out of bed to a wheelchair, and that requires caregiver training. I usually recommend 2 caregivers, so that way one person manages the patient, the other person can push the device. They'll likely need a wheelchair, and there's different types of wheelchairs. There's reclining wheelchairs and ones with high backs and elevating leg rests, and you'll learn about that in physical therapy school, because some patients, like a standard walk or a standard wheelchair wouldn't work for them. It's just a bedside commode. If the patient can't safely walk from their bedroom to the bathroom, we can also recommend a bedside commode, just a little portable toilet that someone would have to empty out. Patients that are bedbound may require a hospital bed to assist with getting them out of bed because it's too hard to get out of a flat bed. And this is the Sarah Steady. It's a piece of standing equipment. A lot of patients in the neuro ICU, we see they have coordination and balance deficits. They're taking steps, but it's all wobbly. It looks, it's ataxic. They look almost like they're drunk, and it's very unsteady. So sometimes patients, so then the nurse would ask me the safest way to get this patient from bed to chair so they can sit in a chair all day for most of the day. And if their coordination and balance is that poor, then I mentioned to them, I recommend you using the Sarah Steady. That way the patient can pull up to stand, and then they sit on there's seat plates that go behind them, and nursing staff can, once they're in this device, push them into a chair, have them sit down in it. So a nice convenient tool that we have here in the hospital, along with many other pieces of equipment that I'd love to share with you if you have time to talk about it after the presentation. So how to become a physical therapist. First you have to graduate high school, then a bachelor's degree that's at a college or university for about 4 years. Some people graduate sooner or later. I didn't know what I wanted to do, so I graduated college a semester late. I eventually decided I wanted to major in kinesiology, which is the study of human movement, and that kind of helped me get into a physical therapy program, which is a 3-year graduate program, and you'll get your doctorate in physical therapy. After that, you have to pass the national PT board exam, and then Depending on which state you want to practice, you do have to get a state licensure exam. So here it's the California law exam. It's about 50 questions about the law specifically to California, and that's through the PT Board of California. If you are interested in physical therapy, kind of like what Lauren mentioned in nursing, recommending volunteering. So volunteer at a PT clinic or here at the hospital. We also have volunteer programs so that you can observe and shadow a PT to see what it entails. I never would have thought I'd work in the hospital because of, there's bloods and lines and drains and, other secretions that I thought was really gross. But shadowing can give you an idea if this is a good fit for you. And you can also work as a rehab aide. So when I was a college student, I had a part-time job. When I finally decided kinesiology, I got interested in physical therapy. I worked as a rehab aide, and it really opened up my eyes. And that's actually what inspired me to get into physical therapy, because it was at an outpatient clinic, but I saw the physical therapist work, and it was very rewarding to see these patients improve. They're getting better. They're so thankful. You're helping them move better and get more independent and have less pain. So I do find physical therapy very rewarding, especially here in the hospital, especially here in the ICU. Again, they're just, they're in a coma for so long, and now they're waking up. Now they can sit up, and eventually can stand up. And the goal of getting them home eventually. And you see a lot of progress. And even if they just, seeing them leave the hospital into the next level of care, possibly a rehab facility, is very rewarding. They're out of the hospital, and you get to be very hands-on as a physical therapist. And I'm small, I'm probably smaller than most of you here, but that's not, something to deter you. There's plenty of resources and support and equipment and things that we can do despite your size. So that's it.
We'll hear from Sherry Aoki, and she's going to talk to us about being a case manager.
How's everybody doing? Looks like we had a lot of great speakers giving you a lot of information. So go over what a case manager is, and that's a good question. Anybody know what a case manager is? Probably never heard of us. We're actually, here at UCLA, we have to be a nurse. And so I went through the same type of program that Lauren did, who's previously spoken about nursing. And to be a case manager is case management, and put it in a nutshell, is we're the air traffic controllers for healthcare. And what does that mean? We direct people in directions of their needs based on situations. Not every person is a cookie cutter, but we have to know a little bit about everything, if that gives you an idea. Okay? And start off with, and I just want you to be aware of our awards. The DAISY Award is recognized in nursing. As we're all nurses, the surgical and transplant services case managers won an award last year, which was a big thing, because that's the first thing for case management to be recognized at this facility. And the little picture is my little group here on with me in the back. So when does this process begin? It starts with admission. And you're going, how can case management be involved in admission? Well, we have to understand what every patient that comes in, what is their needs? What are they here for? As Dr. Holly had previously spoken about that one patient who has the brain injury and the spine injury. So we have to start thinking, where can this person go next after the hospital? Because that's part of our responsibility, is the transition from this hospital. So we have to collaborate with not just case management, just the nurse. We have to collaborate with the physicians, the nurse practitioners, the rehab team, the physical therapists, occupational therapists, speech therapy, because they're gonna have to be able to eat and drink, and also the others is like social work. Social work is an entity that supports the personal needs of the patient or the support system, okay? And where the patient may go is a crucial thing, because are they slated for home? Are they gonna need having needs, such as rehab needs? Are they gonna be able to do, perform the things that you do every day at home, in the home existence? Or do they need to have to go to a facility? And then we do the referral for that facility to get them to rehab, so then they can eventually go home. Or is it something that they need intense rehab? That rehab being working with the physical therapist, like Ron had spoken about, that intensity to get them to a spot to where they can then have a lot of therapy, intense therapy, and then transition back to home. Another thing that's of concern is how do we get there? And it's all based on medical necessity. Everything we do is based on medical necessity, so this way we can figure out, is it something simple that they don't have a ride home? So we figure that out, what would be safe for them to transition, and it's all about patient safety. And then the other is it an ambulance? They need to go to some of the other continuous rehab, for example. Is it, do they need an ambulance? Do they need air ambulance? Like right now, I'm setting up an air ambulance for someone to go to Las Vegas because they're on a ventilator still. They have something called a tracheostomy, a tube that goes through their throat to help them breathe. So the safest way for them to go would be by air ambulance. So there's multiple things that we get involved in. I try to keep it kind of sweet because it's so diverse. I mean, there's multiple types of case managers out there. I'm an inpatient case manager. The one thing I did, nursing is my second career. I started off in aerospace, and then I made the career change to nursing. As through my nursing career, I had an injury, and which limited me from doing the things that nursing would need to do, physical things. So I had the opportunity and learned about case management and learned how much more I had the ability to be an advocate for the patient, because that's what it is all about. It's our advocacy, and also try to provide that better situation for them. Right. Sometimes, as we see in the ICU, sometimes why they're there is not always ideal. I mean, who wants to come to the hospital? But we're gonna try to make that improvement and make it a better situation for them. So, great deal of pleasure of being an advocate and making a situation better for them. And that's part of case management.
So next, we're gonna have Ann Hoffman, who's actually a researcher in our department who does brain injury research, and she's gonna talk about the research career and kind of how that ties into our case.
Hi everyone, I'm really excited to be here. My name is Tamkin Auditorium. I am a neuroscientist, and more specifically, I'm a behavioral neuroscientist, which means I'm really interested in how the mechanisms of the brain control our behavior and mental health as well. And I work in the departments of neurosurgery here at UCLA, as well as in psychology. So just a little bit of a background of my research path, my academic path. We're gonna go from right to left on the map. I first went to college at the University of Pittsburgh. I grew up in Pennsylvania. I majored in psychology, and before I started college, I had never even heard of the field of neuroscience. It was through my courses in psychology that I was really drawn to the more biological psychology. So I picked up a neuroscience minor at Pitt, and this is also where I had my first research experience. So I volunteered in a couple different labs when I was in college, and it wasn't until I found a neuroscience lab, and specifically one that studied traumatic brain injury, that I really got excited about research and knew this is what I wanted to move forward with. So in college was a 4-year degree, and I spent a year after college working as a lab technician in the lab that I worked in before I went to graduate school. So then I did graduate school at Arizona State University in a PhD program, a doctorate program, where I studied in the neuroscience of stress. So how the brain and behavior and how learning and memory is affected by periods of stress. And the PhD program is about 5-6 years of training, and something you might not know about PhD programs and PhD school is that in most cases, the tuition is covered, so you essentially get your degree where you don't have to pay for it, and you can also do things to get paid in graduate school, like becoming a teaching assistant and also doing research. This is a really nice opportunity to become an expert in something you're really excited about. So after I got my PhD at ASU is when I joined UCLA, and I became a postdoc. So a postdoctoral fellowship, or postdoc, just means an additional training period where you're working in a lab, getting some additional training, but it's a full-time job. You're a full-time researcher. And here at UCLA, so after my postdoc, I stayed on and continued to do this research where I'm interested in the interactions of traumatic brain injury and stress. So that's my research specifically, and you don't necessarily have to do a postdoc after you get your PhD to stay in science. You can go work for biotech companies or pharmaceutical companies and things like that. There's a lot you can do with a PhD outside of academic research, but I found that I loved academic setting. I love making discoveries and just having a lifelong career of learning, and like constantly, I'll never not be a student, which is something I really enjoy. And so for my day-to-day is we conduct research experiments in the lab. So I'm interested in, as I said, how we respond to periods of stress. So in the lab, we use rodent models, so rats and mice. And we can ask questions in these types of experiments, and specifically on how the brain is affected and how the brain orchestrates these changes that we can't ask in people. So we can't set up these experiments in people. So we have a lot of really fun tools to be able to do this. So we can do kind of traditional maze tasks where we just observe animal behavior. These mazes, the pictures of the mazes here, depict kind of tasks where we look at anxiety behavior. So for example, this one here, we can measure the amount of time that a mouse might spend in a dark compartment where they're maybe more safe, and watch how they explore in the more open areas. So they're motivated to explore, but they also want to stay safe. So in a more anxious mouse, they might spend more time in the dark compartment, or a more stressed out animal. And then we can also do really cool things like change the activity in brain cells with the application of a laser, like in this picture of the rat here. And then other things we do, we look directly at the brain. So we can use maps of the brain, like this rat brain atlas, to locate and find and dissect the specific regions of the brain that we're interested in targeting and interested in studying. So we have our lineup of rat brains here. We can freeze them, put them on this machine here called the cryostat into very, very thin slices of brain tissue, put them on a microscope, and then visualize it under the microscope and see, for example, after a traumatic brain injury, what are the changes that we see? And we can apply different treatments in order to conduct experiments to see how we can find improvements in our conditions. And so the goal of our career is to advance science and medicine. And so we can ask really broad questions like, how does the brain work? And get more specific with questions like, how does the brain work after you've had a concussion or severe traumatic brain injury, like our case? We do collaborate with medical doctors and healthcare workers. So I'm not a healthcare worker, unlike I think most of the panel today, but we have direct interface. Especially, it's really nice to work in the lab here at UCLA, where we have an ongoing collaboration, especially in the neurosurgery department, with surgeons, neurosurgeons, and neurologists that work directly with the patients. And we can take for example, like the case today, and set up an experiment and ask questions about, for example, what is the optimal course of treatment for a situation like this with such a polytrauma or two different types of injuries. So that, and with something like brain injury that's inherently unpredictable in people, we can set up experiments where we can control the variables, look at specific things like timing that you really can't have trouble controlling with when you're dealing with patients and human data. And so that's known as translational research, and our goals are to develop better treatments for injury and disease, to better understand how our systems, our biological systems work, and ultimately to improve human health and animal health is where that's always important to us as well.